So surgical management in these two most important things, one is the gastrectomy and one is the lymph nodal dissection. So gastrectomy, apart from the traditional traditional gastrectomy in invasive malignancies where we need at least 5 centimeters per positive margin, the Japanese guidelines have advocated for at least in early gastric cancers at least 2 centimeter proximal margin. And gastrectomy in early gastric cancer we can have for a partial gastrectomy or a functional gastrectomy wherein we can preserve much of the stomach function. And in these, there are 3 types of gastrectomies. One is the proximal gastrectomy, one is the pylorus-preserving gastrectomy, and one is the distal gastrectomy. Regarding the management of nodes, lymph nodes, traditionally any invasive malignancy and any traditional gastrectomy for invasive malignancy, it is D2 lymphadenectomy or D2 plus lymphadenectomy, which aims for very good survival. But in early gastric cancer, based on all the Japanese guidelines, it is D1 lymphadenectomy or D1 plus. We need not go for a D2 lymphadenectomy, so we can probably preserve the morbidity of the patient for this D2 lymphadenectomy. So, as I said, proximal gastrectomy. This is basically for tumors involving the cardia or the upper body tumors, wherein in invasive malignancy we usually go for a total radical gastrectomy with D2 lymphadenectomy. In this early gastric cancer, we can preserve more than half of the stomach volume, and reconstruction options are either esophagogastrostomy, or you can put a jejunal interposition tube, or you can do a double-tract reconstruction. So in esophageal gastrostomy, it is a simple procedure wherein single anastomosis and patient can be discharged early. But the most important problem is the bile reflux esophagitis which we get. So there are some certain modifications that can happen. That is tube formation of the stomach or a modified fundoplication wherein we wrap the remaining part of the stomach over the anastomosis. Then jejunal interposition, wherein we take a pedicled graft of jejunum and interpose it in a properistaltic way in between the esophagus and the remnant stomach. This will significantly reduce the incidence of bile reflux esophagitis, but it increases the overall time, overall OT time, also overall increased hospital stay length. Then the other modification is a double-tract reconstruction, wherein we create a Roux limb of jejunum and take it and anastomose do a esophagojejunostomy, and we also do a gastrojejunostomy to the same limb, so that physiologically we are preserving the stomach and we are reducing the bile reflux issues. So these are the reconstruction options I was talking about just now after proximal gastrectomy. One is the esophagogastrostomy, and one this is a double-tract reconstruction wherein we do a Roux-en-Y esophagojejunostomy, and the same limb we attach to the remnant stomach. So this should be at least 15 centimeters, and beyond 15 centimeters should be the gastrojejunostomy, and beyond the gastrojejunostomy it should be 20 centimeters before we do a jejunojejunostomy to prevent reflux issues. This is the same reconstruction, that is a double-tract reconstruction after proximal gastrectomy. And regarding the lymphadenectomy, as I said, D1 lymphadenectomy is recommended by the Japanese guidelines in early gastric cancers. So these are the level of lymph nodes which we remove for proximal gastrectomies. Then comes the distal gastrectomy, one of the most simplest procedures which are done in tumors located in the pylorus or distal body or antrum. And reconstruction is in a traditional way, that is either Billroth I, Billroth II, or a Roux-en-Y gastrojejunostomy. So Billroth I gastrojejunostomy, it is one of the most common reconstructions, and it is a physiological. I mean, the food goes from stomach into the duodenum. So there are no physiological changes in this, but the reflux, bile reflux gastritis is a major issue. And it also has a low single anastomosis, so chance of anastomotic leak or internal herniations are less. Billroth II gastrojejunostomy, wherein we create a loop of jejunum and we do a gastrojejunostomy. We generally add a bronze jejunostomy to prevent all the complications of post-gastrectomy or post-recon syndromes. Then comes Roux-en-Y gastrojejunostomy, wherein we create a Roux limb of jejunum and anastomose to the remnant stomach, and 40 to 45 centimeters beyond we add a jejunostomy.